Hey, it's Denise. It is the day before my skin removal surgery. I would be lying if I said I was anything other than a nervous mess because I am. Um, if you've had, obviously, you know, most weight loss surgery now is done laparoscopically. My sleeve gastrectomy was done laparoscopically. I'm not talking about that kind of surgery. I'm talking about if you've had large incisions like C-section, um, any other procedure where they had to make a big incision. You know how much it hurts when you wake up and you're in that recovery room, and the first thing you want to say is like, oh my God, someone get me some pain medicine. And of course, the first thing you can say is like, you think you're asking for pain medicine, but you're not even really speaking English yet, or whatever language you might be attempting to speak. So, having had my share of surgery with incisions, other than laparoscopic, yeah, I know what I have to look forward to tomorrow when I wake up. So I'm having the loose skin removed, and now here's where it gets a little confusing. When I saw my doctor, it sounded very clearly 100% that I was having the diastasis recti repair done. That's where the muscles in your stomach, usually during pregnancy, um, the muscles actually separate. So instead of lying against each other in the middle, your abs where they should be touching, they actually have separated. And like if I were to go to do like say a crunch or lift my feet up while laying down, instead of pulling flat the way your abs usually do when you tense them, if you have this problem, they kind of bulge out. And it is something that they can fix while they're in doing, to do the panniculectomy, the skin removal, the loose skin removal. They're cutting you from hip bone to hip bone. So it's a good time for them to get in there, and the repairing of those separated muscles is considered medically necessary because you have the greater chance of herniation happening, and then that would require a whole separate hospitalization and surgery. So while they're in there, it just makes sense to have it repaired. Although from what I've seen, watching other people talk about it, people who've had multiple surgeries, and they're kind of comparing this to that, it sounds like it ranges from, yeah, it's about as painful as a C-section recovery, to, oh my God, it was 10 times worse than my C-section. I've had 2 C-sections, the bikini cut and then the vertical, which I think last time I made a video and mentioned it, I said horizontal when I meant vertical. So yes, I had the bikini cut across, and then I also had one from like bikini up to almost belly button for my second son. And my second son was over 10 pounds, and that's during that pregnancy is when the diastasis occurred most likely, because after my first son, who was 9 pounds, I took about 3 months, lost the baby weight, and fit into my jeans. Second son, same thing, about 3 months, lost the baby weight. My waist was 2 inches bigger, a full 2 inches, like 2.5 maybe. Like, there was no fitting into the pre-pregnant jeans, even though I was at the pre-pregnant weight. And I think part of that might be because the muscles separated. So I don't know if fixing them will have any impact whatsoever on my waist measurement. It may not. I really don't know. But it will prevent that from being an area where herniation is more likely to occur. And if it can stop me from, potentially getting a hernia there and then needing, additional surgery at a later date, then to me it's well worth it to have it done while I'm having the excess skin removed anyway. So at this point, I'm at Sal's house, my best friend, who you hear me mention frequently, and my mom is going to be picking me up because I kind of need to leave my car here because I'll be going home from here. My mom's coming to pick me up at some point, probably relatively soon. to take me to her house for the night so that she can get me to the hospital in the morning for my surgery. As of yesterday, when I spoke to the OR scheduling person at the hospital, they said I was my surgeon's second case of the day. So they will call this evening to confirm what time I have to be there. But she said probably assume sometime around 7. She also told me to assume probably I'll be under anesthesia for between 2 and 3 hours, depending on how the surgery goes, but that's the average. And one thing I found a little unsettling is that she had no mention of the diastasis repair. She had purely that I was there for the panniculectomy. And she suggested that I should call the surgeon's office and just clarify. So I called and left a message, and someone got back to me, and they said that he doesn't put it on the schedule necessarily because once he does the initial big incision, when he gets in there and can actually see it with his eyes, he can make the determination if basically enough scar tissue has formed, I guess, that it wouldn't be considered a risk maybe to leave it, even though the muscles are still separated and do, bulge upward. I guess maybe if there's no risk because there's so much scar tissue holding it together, maybe medically it's no longer a risk. This is just my guess as to why you would not fix it after you told the patient you were going to fix it. Because it seems like now the answer is, well, once he gets in there, he'll decide if it needs to be fixed. I don't know how you would all feel about that. I'm feeling a little uneasy. This is major surgery. From my understanding, it's the more painful procedure to recover from because there's lots of internal suturing. But I do want, like I said, to be rid of that risk and to be rid of that weird uneven bulge that occurs anytime I tense my abs. I feel like I've lost about 100 pounds, and it would be nice if besides the loose skin removal, if I didn't have this uneven, weird, aliens are trying to burst out when I do a sit-up stomach. So I really am not thrilled with the idea that I'll be going under anesthesia, not knowing if when I wake up that the surgery I'm expecting is going to have been done or not. I don't like that. Yes, previously labeled control freak, I know that. But something as major as whether or not a significant surgical procedure is being done, obviously I'm going to be under general anesthesia now when that decision is made. I don't like that. I don't like it at all. But apparently this is not uncommon for them to wait till they actually can visualize it to determine if it is medically necessary to fix it, even though they've already told you twice that while they're in there doing this other surgery that they would fix this. So I have a little bit of a not great feeling about that, if I'm being 100% honest. I don't like that. I don't like being told, yes, we're doing this, and now it turns out we're only definitely doing this, and while you're unconscious under general anesthesia, without your input, we'll be making the decision as to whether or not the other thing is getting done. So I'm a little apprehensive about that. Of course, there's the normal apprehensive. I'm not one of those people who's afraid they're going to die. And, some people have this thing, they're afraid of being knocked out, that they're not going to wake up. Maybe it's because I have been knocked out a number of times and waking up, other than the fact that you're in pain and maybe nauseous, was fine. I never had any sort of serious complications from anesthesia other than vomiting, which they will be pre-medicating me for because obviously after a big abdominal incision, the last thing they want is you vomiting. So they did, the nurse, the pre-op OR nurse, did discuss with me medications because I do have a number of medication allergies, including to compazine, which is one of the common anti-nausea drugs that they use. So they have to get a little creative with what they're going to give me to prevent the vomiting. Other than that, I'm just trying to stay relaxed, which is a chore because, this time tomorrow, I will have had my surgery done. I'll have a big old suture line, so to speak, and although he said all the suturing will be on the inside, that there'll only be steri strips on the outside. I'm umming a lot. I think I do that more when I'm nervous. And I know how much pain you're in right after surgery. Like I said, not my first rodeo, as far as non-laparoscopic, actual, big open type surgery. So yeah, I know the pain is going to be significant. As much as doctors love to tell you, oh, the pain's not that bad. I was a nurse for 26 years. Do you know how many times I heard doctors say to people that a particular procedure was uncomfortable, but not really painful? Meanwhile, I'm sitting there thinking, oh, that's really not the truth. What they're going to do to you is going to hurt. Especially like if it was something that I've had done to me. And I'm just like, how do they live with themselves just standing there telling people, you'll experience some discomfort. To me, discomfort is like if you take some Tylenol, it will go away. That was discomfort. If you're in like screaming, like wanting to cry, curled up in fetal position, it hurts so bad you want to crawl out of your own skin, Tylenol is not going to help you. And I'm sorry, but you're in pain. You're not in discomfort at that point. So it makes me a little anxious when I'm having such a large incision, possibly the second surgery that, like I said, up until yesterday, I thought I was definitely having, and now I'm not knowing if I'm having it. So that will, I guess I know I'm going to wake up in pain. I don't know how much pain to be expecting to wake up in. And being told, oh, my patients go home on Tylenol usually. There's so little pain. And like I said, that sounds to me like the, oh, this doesn't hurt, you'll just feel some discomfort that I've heard said so many times. So I'm really hoping that's not the case. And I'm hoping that I will get pain management that is adequate to the degree of pain that I'm in. Now, I am not a baby, but I also don't expect, if I'm in a hospital where they have the ability to manage the pain so that for the first, you're only there for 24 hours. For that first 24 hours when the pain is going to be at its worst, I want it managed. The pendulum on pain relief has swung so far the other way. It used to be they didn't think we addressed people's pain enough. While I was working as a nurse, we actually had signs all over the hospital that pain was the fifth vital sign and was to be treated as such. And that the only person who can tell you how much pain they're in is the patient. You don't guess. You don't assume they're not in pain. You don't assume they're exaggerating how much pain they're in because everyone's pain reception, experience of pain is different. And also people's tolerance of pain is different. And it doesn't mean you're a weak person. It just means your body doesn't handle the stress of pain as easily as maybe someone else's body does. So I'm not attaching any sort of value judgment by saying that some people have a lower pain tolerance than others. It is what it is. So, it became like right in the patient's Bill of Rights was you had the right to pain relief. And now, because of the amount of opiate abuse that is out there in society, the pendulum has swung the other way to the fact that my primary doctor is not even allowed to prescribe me pain medication anymore. How sad is that? If I have a flare-up of a chronic but episodic condition, like I have inflammatory bowel disease, The main treatment to fix it is steroids. I have to go on prednisone when it flares up. But for like the first 2 days, basically, the pain is terrible. And my doctor used to let me be able to have on hand medicine so that if I had this, because when it starts, it just starts. There's not like you get 2 days warning that it's going to happen. So, and those type of things love to start on like a Friday at 5 o'clock when you can't reach anybody at your doctor's office. So my doctor always made sure that I had, a small amount of it at home so that if it did start, I would have enough on hand to get through it. And I always have the prednisone at home because, like I said, I've had this condition a long time. I know when it needs to be treated. When I have to start taking something for it, I do immediately call the doctor's office and leave a message and let him know, yeah, I'm having a flare-up, so that he can then call in, basically, because I'll have the medication that I'm using to get started with the treatment, but I'll need him to call in a full prescription worth so that I can finish this treatment, and then I'll still have some left to start again for the next flare-up. That system has worked for us for years. So my doctor knows that I'm not going to take the stuff until I, really have tried letting it settle down on its own, which on occasion it will. But usually once it starts, it's not going to get better without the prednisone. So it's pretty sad that now my own primary doctor isn't allowed to prescribe any sort of pain medication for me, even though he's been taking care of me for years and knows me better than if I went to a specialist or have a hospitalist taking care of me if I were ill in the hospital. And yet they're not allowed to do it anymore. So I did speak to my neurologist, who I had a checkup with and saw yesterday. And he was willing to prescribe a small amount so that I can keep it on hand on days that the other medications I take do not work for my migraines, basically. But you can't take medical marijuana on the same day that you're taking any sort of opiate, because New York State's philosophy is that the marijuana is in place of an opiate. Now, if you know anything about the chemistry of those two medications, how they affect the body, what they do, that concept is a joke. They treat very different things in a very different manner. For me, the medical marijuana has gotten rid of the nausea that had me unable to keep fluids down, that had me needing IV fluids regularly because I couldn't drink enough after my weight loss surgery. It's helping with the neuropathy pain that I've lived with ever since my spinal cord injury, and it's helping with the headaches. Now, does it give pain relief at anywhere near the level of an opiate-based medication? No, it does not. It absolutely does not. It's not hitting the same receptor sites in the brain. It's apples and oranges. They do two completely different things. So, and I got the feeling that my neurologist was like, yeah, preaching to the choir here, but he's got to follow their rules, or else they could take away his speak English, Denise, his right to prescribe things. So he had to advise me that the actual pain medication is only for breakthrough pain, and that if it's a day that I need to take that I do not take the medical marijuana on the same day. So, okay, no problem. Take pretty simple directions. I can follow that. But that medicine's called into the pharmacy by my house, where I won't be for a week. So it's not going to help me with the post-op pain, because hopefully by the time I'm home, the worst of the post-op pain is going to be over. It's going to be it'll be 6 or 7 days, depending on what day I get home. Anyway, just wanted to kind of say that that's where I'm at. wish me luck. Like I said, I'm nervous. Not in that fear of dying way, just more in the I know I'm gonna wake up miserable, like I always do from anesthesia, like most people do, and I'm just worried that they seem real casual about the pain management approach, which, like I said, I'm not a baby, I'm not a wuss, but for the first 24 hours after you have just cut me literally from hip bone to hip bone, and, you know, if you've ever watched the surgery, the panniculectomy, it's pretty rough stuff being done to your body, and a whole lot of suturing inside. A lot of it is the sutures that melt over time. So it's not like you're having a lot of sutures removed. A lot of it is internal suturing, but that still causes a lot of pain. So yeah, I feel like a bit of a wuss worrying about it this much, but I don't dig the, oh, Tylenol will be enough speech. To me, that rang, very much of the, oh, it's not pain, it's just uncomfortable. And you're like, oh yeah, don't believe that one. So hopefully I'm wrong. Hopefully it is not that bad, and when I wake up, I won't be doing that I think I'm saying, someone please give me something for pain. And hopefully I will be well enough to make a little video on my phone, which I'll have with me while I'm in the hospital. I should only be in over one night. If I'm too out of it and sleeping, then obviously I'm not going to make a video. But if I can, by the evening, I will try to make a little video to tell you, at least, just even if it's just a couple minutes, just to say kind of how it went, the waking up from it, how I'm able to move around. I know I'm going to wake up with 2 drains hanging out of me. So, I will, if I'm able, make a video. Otherwise, once I'm discharged and back here and feeling up to it, I will make a video and try to fill you in on what that first day is like afterwards. So, thank you for watching, and I always appreciate your taking the time to watch one of my videos. If you're not already subscribed, please do so and give me a thumbs up. And have a great day. Take care of yourselves.